Welcome to Dementia Demystified Session 2. My name is Peter Silberberg. I'm a GP and I'm a Dementia Training Australia medical educator, and I'm joined by my good mates and colleagues tonight. Rebecca Moore. Hi, Beck.
Hello, how are you?
Beck's a GP and also a Dementia Training Australia medical educator. And Mark Yates. Hi, Mark.
Hi, how are you, Peter? Hi,
Good,
Beck.
thanks, mate.
Hello.
Good to see you.
And Mark's a geriatrician. So we've got the A team presenting for you tonight. And welcome to you all wherever you are. So before we get going, we, the FACE team, DTA, and all the people in this meeting tonight would like to show our respect and acknowledge the traditional custodians of the lands that we're meeting on tonight. We extend our respect to elders past, present, and emerging, any Aboriginal people joining the meeting tonight, and pay our respect to those peoples living with dementia and their carers who are Aboriginal and Torres Strait Islanders. This is a reminder that if you don't have this QR code yet and a link to the FACE Dementia resource page, then scan it in now because it's awesome. Really, really good. And we're going to be using some of the resources on that page tonight. And a reminder that Dr. Mark Yates has his drop-in sessions. You're still running them, aren't you, Mark?
Well, I am still, I think probably for the next couple of weeks. It hasn't been something that people have jumped to, but I'm still opening them up, and I see who comes along.
When are they again?
It'll be on the website. The next one is on Friday.
Right.
And then they're on either Wednesday mornings or on Friday afternoons, once a week.
Check it out. And so this is, thank you for coming back. By attending this workshop, we very much hope that you'll be able to identify and address what we call modifiable risk factors to help prevent, delay the onset, and slow the progression of dementia. We also hope that you'll recognise the changing goals of care as dementia progresses over time, and to be able to implement an effective care plan or management plan for people living with dementia. And it's always good to begin with the end in mind. So we now know, fresh, hot off the press, that 45% of people living with dementia have an attributable modifiable risk factor. And we're going to delve into that a bit more detail in the webinar tonight. It used to be 40%, it's gone up to 45. So that's good news that there are more modifiable risk factors. The second point is that most people living with dementia, you as the GP can both diagnose and initiate care for them. And we're really passionate about that. And it's really important that you feel confident to do that. And despite there being no curative treatments for dementia at this stage, there are many interventions that improve quality of life for people living with dementia and for their care partner. And we'll be going over them tonight. So we're going to just do a quick revision from the previous webinar. So just to remind you the steps to making a diagnosis of cognitive impairment and then potentially moving on to a diagnosis of dementia. So the first thing is always be on the lookout for how people can present. And that might be in your room as a consultation. It might be how they present to reception. It might be a phone call from the carer or something else. Understand the inclusion and exclusion criteria, which we will revise briefly. Use the domains framework to take a history, complete your focused examination, complete a cognitive assessment tool as appropriate, your investigations to help rule out other causes for cognitive impairment, reapply your inclusion and exclusion criteria, and then hopefully you will come up with an answer to what's in front of you, possibly a diagnosis of cognitive impairment and possibly even dementia. And if needed, give Mark a call on a Wednesday or Friday for the next few weeks, or the nearest geriatrician to you.
And remember,
so
remember that they don't have to. It doesn't have to be all done on one consultation. You can do these in bits and pieces. So there's an opportunity to do it.
Oh no,
flights.
Mark, I do all mine in 15 minutes.
Well, that's amazing. It takes me an hour and a half.
That's not AF. Super GP. So, Beck, the inclusion criteria. Briefly revise people what the inclusion criteria are for making a new diagnosis. Yeah.
Certainly. Before I do that, Pete, can I just mention if anyone has any questions, we're very happy to take questions as we go. And you're very fortunate because not only do you have Pete and I here, but you also have Mark. So you've got a good panel if you've got any questions. But in terms of the inclusion criteria, we talked about this a lot last time. Essentially, to make a diagnosis of dementia, there are 4 things you need to consider. Firstly, there needs to have been a gradual onset of a decline in cognition. And so that is, it has to have happened over months rather than more acutely over days, essentially. There has to have been a progressive decline, so it has to be getting worse. And in order to make a dementia diagnosis, you have to be able to show that it's affecting function significantly. You may remember we spoke about mild cognitive impairment. That's where you do have a change in cognition, and that's but it's not to the extent that it's actually affecting function significantly. In order to make a dementia diagnosis, we need to see that there have been changes in a person's ability to manage in terms of looking at cooking, cleaning, shopping, banking, those kinds of activities of daily living. And of course, we need to make sure that it's nothing else. So that's where we have to look at the exclusion criteria, the things to rule out.
That's right. And Mark, maybe I'll get you to go over the exclusion criteria. So these are things, other possibility causes for a change in cognition that you need to think about and exclude, or you can be left with a diagnosis of dementia. Maybe just give 1 or 2 examples of each point.
Yeah, I mean, obviously, someone who's confused because they've had a nasty urinary tract infection, remembering that delirium can persist for about 6 weeks after the infection's actually been resolved. Clearly, alcohol and other drug use is going to mimic the cognitive change you might see at assessment, so make sure they're not been drinking. The major mental health orders, particularly, long-term schizophrenia and other things and also unstable and poorly managed depression, real problems in this space. I think one of the hardest differentials is separating depression from dementia, and I actually sometimes go to my psychiatry colleagues for that advice. And then uncontrolled and poorly managed other organic disorders can make things a whole lot worse. So you may have someone with just mild cognitive impairment, which isn't true dementia, but their diabetes is diabolically managed because they haven't quite got their act together. And then their cognition is a whole lot worse than it really has to be. But get that all tidied up first before making a formal diagnosis.
That's great. Thanks, Mark. And what would be the commonest prescription medication that you'd see in your practice that affects people's cognition in terms of other drugs in point 2?
Oxybutine would be one for bladder stabilization, and potentially some of the older antidepressants often used for pain management, so amitriptyline.
Right. Excellent examples. So these are the domains of dementia, and this is to remind us that dementia is a syndrome that affects the whole person, and we've divided that up into what we call the 5 domains. This is a really useful framework for taking your history, but thinking about the illness in general. We've talked about the cognitive and functional changes. Mark's mentioned about the mental health symptoms. In this slide, you're both thinking about potentially depression or some other mental health issue as a cause for the cognitive change, but also the person may have some reactive mental health symptoms or a new emergence of a depression from the dementia itself. And that includes also psychotic symptoms. Behaviour changes, don't forget them. They're the things like can either be outward going, where the person may be disinhibited, or it could be the opposite, where they become more withdrawn. And the last one is physical decline. These changes can be very subtle early in the progress of a dementia and are generally much more obvious later in the later stages of dementia, things like swallowing, eating, talking and walking. And these are the stages rewritten again, and this is a really useful framework because it gets you to think about the person sitting in front of you and where they are in their journey and potentially where they may be moving towards, so you can be proactive in terms of what you're going to think about doing. So today is all around care of the person. And part of the important principles we're going to talk about is to think about what is going to come next. So in stage 1, the person is generally is still at home mostly. The functional changes are there, but they're milder, and they're able to live with support from their carer, or maybe NDIS, or maybe my aged care package, these kind of things, and they're still safe. As the years go past and they progress, their caring needs escalate, and they're heading towards needing transitional 24-hour care. So the things you're seeing there are behavioural changes, maybe wandering, maybe leaving stoves on, maybe other dangerous activities, or maybe things around transferring from sitting to standing, going into the bathroom, falls, and continence. They're the sort of things that really provide challenges for carers at home that often lead to transitioning to 24-hour care. And then the last one is when the person's generally almost always in a aged care facility where they're in the final stages of their life and their independence is vastly diminished, and they're needing people to assist them to do all sorts of parts of basic daily activities, and a physical decline ensues, and if eventually many people die from this illness.
Hey, Pete.
Yeah.
Thinking about this physical decline stuff and the stages and what we talked about last week with the differential diagnosis, I often think that the patient who's got a lot of physical change early, like their gait changes and early incontinence, makes me worry more about a vascular cause of their cognitive problem rather than an underlying Alzheimer's cause. So if you start seeing someone who's falling and their gait's funny and they're incontinent very early in their journey, that helps you differentiate out the potential causes. So it's quite important to think about all those stages, but all those domains, as well as the stages, because it's really helpful.
And do you know why that is, Mark?
Yeah, principally because the neurodegeneration in Alzheimer's disease is predominantly temporal lobe and parietal lobe, which is the non-subcortical pathways, whereas vascular injury is the subcortical pathways, like the connection to the detrusor center for the bladder, the gait cadence centers. And so all of that changes early in vascular dementia, whereas you wouldn't expect to see someone with urinary incontinence early in the course of their Alzheimer's disease.
Right. That's really helpful. Thank you. And so when you put all that together, you get this beautiful picture that we've created for you. And Beck, why don't you just talk people through this briefly?
Certainly. So clearly, this is a trajectory for Alzheimer's disease dementia, and certainly the straight lines are by no means really straight. Essentially, we know that an Alzheimer's disease dementia will start with a mild cognitive impairment, and that's when we start to notice some changes in cognition, but people's function remains relatively intact. And, from the very get-go, you may be noticing those mental health changes. Sometimes they can even be sort of a prodromal thing to be on the lookout for a developing dementia. So then stage 1, we start to notice a change in both the cognition and the function. And then in stage 2, the physical changes tend to become more prominent. And you'll see that that really messy area between stage 2 and stage 3. And I think that's quite a metaphor for how things actually present in real life as well. This is often when families are really struggling, and unfortunately, that's often the time in which the diagnosis for dementia is made. Now, what we're hoping is that you'll be able to recognise the changes much, much, much earlier in order to kind of anticipate and therefore much better manage that stage there. And then in stage 3, the physical function tends to decline considerably, and often the behavioural changes will strangely start to settle at that point as well.
Yeah, so that's really helpful, and we're going to basically today talk mainly around the stage 1, and we've got some other education material around the later stages, but we can't cover for a 10-year illness in one one webinar tonight. So we're going to mainly focus on stage 1. But the take-home message really is, again, to be proactive. So I've got someone at the moment who is probably in the middle of stage 2, and the falls are becoming more prominent. And we almost had a hospitalisation for 24 hours, but then he couldn't handle it and had to go home. And so he is my feeling is probably in the next 6 months he's going to be needing 24-hour care. And so you're thinking, in my head, most important thing to get actively going now is a reassessment for his aged care package, an assessment about respite for the family who are starting to get very stressed around caring needs, and making sure that they've had a look around about where possibly he would go eventually.
Yeah.
So that would be an example about thinking forward for someone in the sort of stage 2 progressing to stage 3.
And Mark, you've just made that very good comment in the chat box that the mild cognitive impairment, whilst it definitely is a precursor in Alzheimer's disease dementia, many people living with mild cognitive impairment will remain the same or potentially revert to normal cognition. And so having mild cognitive impairment does not necessarily mean somebody will go on to develop a dementia. But if they have Alzheimer's disease, it's highly likely.
Yep, I think it's that opportunity is a really wonderful window to introduce a lot of the preventative stuff that we're about to talk about. There's a great segue. Boom, boom.
There you go.
There you go. Thanks, Mark. So we're going to take a step back now and talk about what we call modifiable risk factors. And a part of this concept is really talking about prevention. So the next part of the talk is going to be talking about sort of action stuff you can do during the illness. But this is about prevention. And also this stuff you can also do later as well. But it's really important because at this stage, as you know, we don't have a cure for dementia. There's no, even the new monoclonal antibodies that everyone's getting very excited about, they're not curative. They're being talked about disease-modifying drugs. And even then, there's some controversy around how beneficial they're going to be. But I don't want to take away people's excitement because it's been decades since they've had anything new come out, and this is the first thing that's come out. So that is good news. So the Lancet Commission in 2020 did their first report, and they came up with initially 12 modifiable risk factors, and then they recently, about 2 weeks ago, brought out their 2024 commission, and they've increased it to 24 risk factors. So what they've done, and I'd recommend
14.
Sorry, 14. Did I say 24? Sorry, 14, thanks. Yeah. What they've done is they've looked at the data where there's good, strong evidence from the entire globe. So what's sitting in front of you there is for the entire globe, including low socioeconomic countries all the way up to countries like Australia. And then they've tried to work out the percentage of risk that it contributes towards likely getting a dementia. And they've also tried to think about it in which stage of life. And so that helps us in terms of targeting our interventions. So we'll just go around and give away some take-home messages. My first take-home message there is it's never too early and it's never too late. So they've got early life there, quality of education 5%. I would say they've missed something there. You really need, it's also preconception. I have patients who have fetal alcohol spectrum disorder from drinking during pregnancy. That is a brain injury that doesn't progress, but I'm sure these people are going to be at greater risk of dementia because they've got less cognitive reserve. So really, it's all the way from like thinking about pregnancy and during pregnancy, but what they've got the good evidence for, which is why it's in their commission, is quality of education in early life, which helps the brain develop and get great amount of resilience for things that happen as you get older. And what about you, Mark? What are a few take-home messages that you take out of this slide?
Well, I take out the concept of where is midlife, and I really think that it's often thought to be 45, but that may be where they were talking about. But I think midlife really goes from 45 through until about 65. And I think interventions along this area is still really, really important. And unfortunately, I don't get to see a lot of people under the age of 65 unless they've got a very obvious dementia. But I think in general practice, where there's a lot of discussion and fear about dementia in the future, and you're trying to get people to be look after their cardiovascular and cerebrovascular health, this is a gift, because you can really argue very strongly that if you've got a family history of dementia, then you should be really working on these things, all of them, to try and minimize your risks.
That's right. So what's good for the heart is good for the brain. That's
Exactly
the catch.
right.
That's the catchphrase. And I have many patients coming worried about cardiovascular disease, and I just say, fantastic, because did you know that everything you're doing now is reducing your risk of dementia? And I reckon that helps, because most people are quite shocked and worried about that statistic.
And I think actually sometimes people, well, in fact, often people are more concerned about developing a dementia than they are developing heart disease, actually. So it can be a bit of leverage sometimes to make the changes.
Yeah. And what's your take home, Beck, from this slide?
Oh, look, I'm very much, I like your concept of, the concept of cognitive reserve. And for those that aren't familiar with that term, the idea of cognitive reserve is that you have more synapses and more neurons meeting one another, and thus more pathways for the brain to function. And so starting from early life with education, with learning languages, musical instruments, sport, fine motor function, those sorts of things. But also we know that some of the other risk factors are also linked to cognitive reserve. For example, hearing impairment, especially in Australia, makes up quite a significant portion of increased dementia risk. And some of the belief is that people who have a hearing impairment perhaps aren't receiving all of the same signals that other people without the hearing impairment are. So things like social isolation are likely also to impact on that cognitive reserve. And I think more recently there's been evidence showing that education in midlife can be beneficial as well. So I like to stress the cognitive reserve side of things, as well as the vascular risk and the inflammatory risk factors. So recently they've just shown that impaired vision is a new potential risk factor. And I think that the evidence behind that is, again, linked to that loss of sensory input, and thus a reduction in the reserve as well.
Are there any? That's great, Beck. Thank you. Are there any questions on the? I haven't got my question box open, so no, that's not. So the one that's been added apart from visual impairment is high cholesterol. So the Lancet goes out of its way by telling us that statins don't increase the risk of dementia, being on statin medication, and their cutoff for LDL they talk about is 3. They do discuss potentially using cholesterol-lowering medication, although the evidence that actually makes a big difference is less, because there's a difference between finding cause and then actually showing that changing something works. But they talk about that in quite detail in the article. Yeah, we had a chat about this beforehand, and I think the best way to think about this is when you're looking at the cholesterol and the LDL, just do it the same way as you're doing for your heart. So use your cardiovascular risk, and if you're using it for primary prevention, which is always the nuanced part of using statins, then use the same risk calculators you're using for the heart. And if it comes up as being high risk or moderate risk and needs doing, or the CT calcium score is high, then get on and give them a statin, because it's going to help their brain too.
Pete,
Is that
can I
fair,
just...
Mark? All right. Yep, go back.
Sorry, I was just going to mention there's a separate study related to this where they have looked particularly at the Australian data. And like I mentioned, hearing impairment is one of our greatest risk factors, but the other two are obesity and physical inactivity. So I think, again, it's all part of that midlife sort of prevention, but encouraging physical activity and reducing weight is obviously super important here in the Australian society.
Yeah, great. So let's say the patient says to you, well, how do I know what I need to do? And you don't have a very long time. So if they have the capacity to do this, particularly if they're, we're talking about prevention here. So someone, in their midlife who's is good at online stuff, then it's a good idea to refer them to this online tool called CogD-Risk. This is being created by Australian researchers, which we should be pretty proud of. And it plugs in those risk factors that you do individually for yourself. And it helps to know what your cholesterol result is. You should give them their, print out of their latest cholesterol. They've got it, and their blood pressure. And then it takes about 20 minutes to complete the online tool. And then it comes up with some things you can do to decrease your risk. So that's a pretty cool thing to do. And I recommend having a go and doing it yourself because it's quite enlightening.
And it's adjusted for age too. So you can do it at later age I think it's up to 75.
Yeah. Okay, so that's prevention. So let's get back to our case, Anna. So we met Anna last time. So just to remind you, Anna has, at this stage, we've taken a history from her and her carer, and we've elicited a gradual onset of cognitive impairment, getting worse over time, that's impacting her function, her gardening, her dressing, her cooking, leaving the stove on, and there was no indication of another cause like depression. The mini mental state was appropriate in her, and it was 22 out of 30, which is below the score of 25 to suggest a potential cognitive impairment. And she also did the clock drawing test for you because that's not included in the mini mental, but it's a really good thing to add in if you're just doing the mini mental because it's got visual spatial stuff, and you can see there that her clock face is not normal. And we've talked about her functional assessment. Physically exam, she was normal. We did some basic investigations, including a CT brain and blood test, which were normal. And the carer, her daughter, was also really worried. So I think we all agreed that in a teaching scenario that she has dementia. So we've done an inclusion and exclusion criteria, and we can't find another reason. And so that is a very logical choice to make. And I'm going to show you a video about giving her the diagnosis, and then we're going to have a quick chat.
So Anna, I've had a good look at all of your results, and I'm pleased to say the blood tests were all completely normal, and the brain scan showed no sign of a brain tumour.
Okay, good.
But what that means is that the likely diagnosis for the cause of the changes that have occurred for you over the last 6 to 12 months is a form of dementia.
So like, that's like Alzheimer's.
Like Alzheimer's.
So Beck, Mark's disappeared off his screen. While I was talking. Oh, there he is. Yeah. So Beck, I mean, this is for teaching purposes. Everyone does it differently. But what did George do well then?
I think, often it's very difficult to actually say the word dementia, and yet it's very important that we're very clear and that we do say the word dementia. And I think he did that well. And actually, Sophie actually helped with that because then she sort of followed it up by saying like Alzheimer's, and he was able to confirm that too. Yeah, Hilton, who one of our colleagues who was Dr. George, he often talks about this concept of the gift of a diagnosis because he, he feels that it helps us to prepare the patient and their family. And yeah, I think generally he did that quite well.
And Mark, you would have many people coming to you who have a possible diagnosis or an unclear diagnosis, and then you have to make a decision and say, no, this is a dementia. Mm. How do you find that process?
Well, first of all, I'm very lucky that you guys have done all the hard work because you've actually got the patient to accept a referral to the memory clinic. So I think that's a really great thing. I think that it's great to have it graduated, and I like to graduate language from memory and thinking difficulties. And if we went to the earlier discussions, there was some discussion about memory and thinking change. And now we're into another discussion, which is a bit more advanced than just memory and thinking change. But I use memory and thinking change first before I use the term dementia or Alzheimer's disease. I actually often couch my initial discussions with saying, look, I think this is an issue, and I might use some scary terms in a moment, and say that people often have a bit surprised by what I might be about to say, and I actually explore whether people rather use the word Alzheimer's disease or dementia, because it's quite surprising that there's different responses to those two things, even though Alzheimer's disease is one of the many causes of dementia. So I love the way Hilton paused after the word, yes, this is dementia, or that he wanted to say something more. And I think that was the invitation for the patient to say, I don't want to hear anymore. And sometimes patients say, I don't want to hear anymore, but hopefully they accept that discussion. And having the discussion about mild cognitive impairment with your practice a lot often opens up an easier discussion about dementia later on, because that term doesn't seem so scary.
That's great. So thank you to both
So Anna,
for that. So we're now going to talk about some overarching principles of care. So there's 7 things on the screen there. We're not going to talk about all of them because that will take too long, but I've just asked Beck and Mark to pick one of their favourite things in terms of that they'd like to highlight to you tonight about some general principles of caring for a person living with cognitive impairment and dementia. So Beck, do you want to go first? Which one would you like to talk?
So yes, I think as GPs, often it can feel a bit overwhelming, especially sometimes a person will have been to the specialist and then been sort of told, well, it's another 6 months until I see you again. And so you get a patient and essentially you're trying to now initiate and form management and maintain sort of a sense of hope and purpose. So I certainly advocate for this multidisciplinary approach, and I start it very early. This is looking in a strengths-based fashion to try and identify areas that are strengths for the person, and also looking for areas that are challenges, but they things that they feel will be very beneficial moving forward to have been able to learn and overcome potentially. So looking at a multidisciplinary approach, all of the allied health spectrum can be very beneficial. We will talk about this a bit more in detail, but certainly I think occupational therapists are underutilised. The pharmacist has a huge role in helping to manage medications. And if you have a good relationship with the pharmacist, that can be a very beneficial thing. Physiotherapy, looking at falls and gait, etc., as well as dentists, podiatrists, speech pathology, etc. Everyone has a role to play. And I think creating a general practice management plan early is really a good idea.
Right. Thanks, Beck. What about you, Mark?
Well, I'm going to quote from the Lancet paper we were just talking about, and that says, people with dementia who become acutely physically unwell and need to be admitted to hospital deteriorate faster cognitively than others with dementia. So I'm going to highlight the concept of the management of other medical conditions. We're good at that as doctors, and you guys as GPs are even better than I am. I tell you what, I ask my wife all the time about stuff I don't know, who's a GP. And just remembering that people with dementia usually also come with 4 other chronic diseases. That's the average. So not only do they have the dementia, but they have 4 other chronic diseases as well, like diabetes, like arthritis, like chronic pain. And in this role, then you can work really well with your practice nurses to address those common chronic diseases, understand that, the management of those requires cognitive skills. And then can you involve perhaps the person's carer or care partner in that care and avoid those hospital admissions that will inevitably progress the dementia.
Fantastic. I have nothing else to add there. Let's move on. So, like I said earlier, we're going to focus now on stage 1 management, and there's a few different ways you can do that. On the left-hand side of the screen with the domains, and you can think about this by what you can do under each domain. And that's not a bad thing. And on the resources, there are some templates that do that for you. But there's also a really good resource, which is called the Dementia Immediate Post-Diagnostic Checklist, which is on the right-hand side of your screen. And we're now going to use that for the rest of the webinar to give you some really concrete things you can do immediately after a diagnosis. I can't emphasize enough the benefit of this checklist. I use it myself, and the main reason why it's so good is because everyone loves a checklist because you can't always remember everything. But like Beck said, it can be overwhelming about everything you feel like you need to do. And if over time, weeks, months, you can slowly just work down this list and do it together with your patient, you will cover just about everything you need to in stage 1.
I often give this now to the patient and their family as well. I know it's essentially for us as health professionals, but actually for very involved families, it's quite handy to give them a bit of a framework as well as to, you know, how to tick things off and issues to look at as well.
So there's the QR code again, just to highlight. Face Dementia has some really great resources for you, including this one. So goals of care. Let's tick box number 1. So the first thing you kind of need to do, or not kind of, that you need to do is you need to think about where this person is in their stage of their illness, and also what it is that they want. So it's a really good place to start, which is pretty much what's important to you. And usually, in my experience, the first thing they say is, I want to stay at home. And you can say, that's a great line. You can say, fantastic. Let's start talking about all the things we need to do to keep you at home. And then you can work through these things together. So I think, you know, can't emphasize that enough. One of the things on the pie was about keeping the person central to the process. And again, asking the person in front of you what it is that is really important to them is a great question. Like Mark said to me in a previous webinar, the person is still the same before they walked into his room and he gave the diagnosis of dementia and they walked out. And, you know, often when you're giving a diagnosis like dementia, which carries weight and significance, that's forgotten, and it's important we keep that in mind.
I think often the families too really appreciate the discussion early, and you know, in my experience, sometimes when the dementia is diagnosed quite late, there's a lot of guilt, and families are really torn as to what the person would like. So being able to discuss it early actually can be be a real relief for the family down the track. You know, if they've already talked about things like going into care, etc., and the person, depending on their insight, has been able to validate some of the concerns, that can be, I think, really good for the family too.
Well, that's right, Beck. That's the gift that Hilton talks about, because knowledge is power. And the other thing is that you just reminded me there is when you say what's most important to you, and they say I want to stay at home. If they don't say I want to stay at home, what's the other thing they generally say to you?
Oh, I don't want to be a burden to anyone. That's what I hear.
Is that one? Mark, another one?
I don't know. I don't know.
Can I help you? Well, there's 2. One is, are you going to take my license off me? Which we'll talk about in a second. And the other one is, are you going to put me in a nurse? You know, don't you dare put me in a nursing home. You know, and so being able to dispel those fears early. Sorry, Mark, I'll just finish. Being able to dispel those fears early is really important.
Yeah, I think the goals of care discussion is interesting because it opens up the question of prognosis as well. Because what your goals of care are really depend a bit about, well, what's going to happen to me in the next 12 months, in the next 2 years, in the next 4 years, because your goals might be different in those. Because many people say to me, can I go travel to Europe to see my family? I'm saying, if that's early, yes, sure. Make sure you go with a friend. You know, if they've got significant dementia, they go with a friend, or make sure there's people at the other end. But those sorts of things are really real to people. And so knowing what's going to happen in the next 12 months, 2 years and 4 years is often something that I discuss as well. And you can predict that pretty well, depending on where the person is in what stage.
Yeah. And this is just to reinforce, tonight we're talking about Alzheimer's, maybe Alzheimer's mixed vascular dementia, not talking about a fast onset Lewy body dementia, an alcohol frontal temporal lobe dementia, these kind of things. So the classic Alzheimer's dementia does take years to progress and is generally a more slow progressive change.
Yep.
So the next thing is education. So we've already started talking about that. We're going to show you some things that can help. So these are some basic principles. So we just talked about prognosis. Fantastic. Thanks, Mark. And refer to Dementia Australia and other support services and maybe your local PHN. I don't know what you guys got down there, Mark, but ours has got some really great resources on our PHN Health Pathways website. I reckon you'd probably have the same. Beck, what's it? We've got Dementia Australia and Forward with Dementia. Both are excellent.
Yeah.
So give us a brief summary of each one.
Yeah, sure. I will just say, often that first discussion where the diagnosis is given, as with giving all bad news, not much goes in, I think, after the original news. And so, it's always important to make sure that you're planning to get the families back and back again with the person living with the dementia. But I tend to refer them on that session to Dementia Australia, and I will direct them to both the Dementia Australia and the Forward with Dementia websites at that very first thing, because when they're not going to take much in necessarily, but it is an opportunity for them to do a little bit more exploring, so that when they come back next time, they've got a bit better understanding of things and have some questions as well. But Dementia Australia have help sheets or, on so many different topics, useful for both the health professional, but also for the person and their family. And Forward with Dementia is especially good for the initial post-diagnostic stages, and some really practical advice there as well. And I think on the next sheet, we've got Carer Gateway. They can be very helpful in sort of providing a navigator to help with the whole process of applying for things like My Aged Care, which can be quite daunting. And also for emergency respite, Carer Gateway can be quite useful as well.
Mark,
what do you?
I was going to ask Mark something. Do you know that if you send, from our practice software, we can send using HealthLink and online referral into My Aged Care. If I, as the GP, highlight a new diagnosis of dementia in someone who's already part of My Aged Care or is starting to access it, does a diagnosis of dementia change anything according to My Aged Care at all, or not really?
Not that I'm aware of, and sadly, the whole My Aged Care process is extraordinarily difficult because they insist on speaking to the individual, and so I found certainly in my clinic, I'm lucky enough to have some excellent nurses who can help actually physically get online with the patient, and as long as they're both online, that's really very helpful. And certainly in my wife's practice, the general practice nurses can be really helpful here because it's quite time consuming, and they're really very good at it. And that's certainly being built in to the GP educational modules that Dementia Training Australia is setting up.
Yeah.
And there's a tick box too, if as GPs that's something that you want to help your patient with, that actually asks for the assessment team to come to the house. And I know that there's a long wait for that, but in my opinion, the team actually coming to the house and seeing some of the challenges that are being faced is a lot more beneficial. So just make sure that you do that drop-down box and ask for a home visit.
The other last thing that I'd like to mention is that in some jurisdictions, so it's a federally funded thing, which I can't remember what it's called, but if you've got a person with dementia who's living alone, or certainly we've just made the diagnosis, their family's in Queensland or whatever, there is a service that's called the Pathway Finder, and will actually come and case manage and support that person through the My Aged Care and accessing things like the carer gateway, etc., to start the process rolling. It's very, very helpful.
Oh, that's good to know.
I'll
Yeah.
go for it.
So on our health pathways, we've got something called a delirium action plan. I'm not sure, is that part of your face dementia resources, Mark? I'm not sure if you know the answer to that, but we'll make sure that you can get access to it. So this is just to remind you, this is like a COPD action plan, and it's a useful thing to give patients and their families, because if you have a dementia, then you're a much greater risk of having a delirium. And a delirium is a medical emergency, and they need to be seen that day. So you need to give them some information around, what if this is happening, if A is happening, then you need to do B, and that's pretty much what's in this plan. So that's worth having a think about too.
I've just put the Care Finder program and link on the chat in the chat room.
Oh, great!
Oh,
great, thanks.
Thank you.
So that's education. So, I mean, look, some of this stuff may seem pretty basic to you, but hopefully what we're giving you is the ability to talk about it with more confidence and with more richness and in-depth understanding about what's out there. Because it is really important stuff. So the next thing's about brain health. So obviously we've just talked about this. So we talked about this in regards to prevention, and now we're talking about brain health in terms of part of your treatment. So Mark, reinforce your message. Why is all this stuff around brain health so important, even with the diagnosis of dementia?
Well, really, because there's a large vascular component to all of the dementia we see, even in Alzheimer's disease. We know, for instance, that atrial fibrillation is a risk factor for Alzheimer's disease, let alone a vascular risk factor. And the second thing we know is that if you've got cognitive change that is related to Alzheimer's disease and then you add vascular injury, it's not a 1 + 1. It's a 2 by 2 effect. So you want to minimize any likelihood of vascular injury you can. So managing all of these vascular risk factors that we've got in front of us are so important in the early stages, either MCI or in dementia.
And I'll add to that, two of my favorites here. Getting a hearing aid on board is really, really important if it's not already done. The other one is social isolation. So there are some good studies that show that getting people to weekly social events helps slow down the progress of a dementia, just as powerful as donepezil, just as powerful as the monoclonal antibodies that are coming online. People don't want to talk about that because there's no money in that, but the evidence is there. So, making sure people aren't socially isolated is really important. And then, because I've got the Kong and I'm going to keep talking for a bit, Beck, my last one is excessive alcohol, because I seem to live in an area where everyone who has dementia loves to drink alcohol up here. And that is just, I think it's missed a lot if it's not asked. And it is a tricky thing to treat. You obviously need to get a really good supportive family on board, because the person in front of you forgets you've had the conversation or doesn't want to stop drinking. But once you take away alcohol, in my experience, it really does make a massive difference. Not surprising, really, when you think about it. You've already got a brain that's already got significant reduced cognitive reserve. It doesn't take very much alcohol to make a big difference to cognition.
Yeah. So
they're my 3 tips. Beck, did you have anything else?
Sleep apnea, I mean, whilst they haven't been able to show necessarily yet a causal link, there's certainly an association between sleep apnea and dementia, and that's probably another thing, looking at vascular risk, that it's important to treat. It might reduce that sort of brain fog as well. And physical inactivity, that's one of those things that you can incorporate with the social isolation as well. If you somebody can join a walking group or activity classes and that sort of thing. I think actually that's one for which the evidence is strongest.
So, Peter, if we want to link the hospital admission stuff and the alcohol and the physical inactivity, and then add in uncorrected visual problems, it comes down to falls. And we know full well that a person with even mild or mild cognitive impairment or dementia who has a fall and ends up in hospital never does so well.
And a head injury is often a trigger for a dramatic sort of decline too.
Yep.
Especially if they're on a blood thinner.
Which a lot of them are nowadays.
Yeah. So that's brain health. So now we're going to do medications. So the first part of medications is just some general information. So look, I think everyone really who has cognitive impairment, who's taking tablets, needs to be on a Webster pack. I think it's just, it should be insisted upon. And there are some pretty cool Webster packs now. You can get some that are locked, so they can't access medication early. They have an alarm, and then it opens the box. They can get into it when it's due to be taken. But, sometimes you need to get extra help through My Aged Care or NDIS or through carers to get people to come around and supervise medication taking, even on a Webster pack. But that's really important. Getting a home medication review is really important. The pharmacist gets to go around to the home. There might be hoarding of medications there. There might be confusion around how many Panadol they're allowed to take, whether it's inside the Webster pack, outside the Webster pack. I get confused with medications all the time. I mean, I can't imagine what it's like being, elderly with cognitive impairment. It's you can't emphasize enough that you really need to address these general issues. They're pretty simple things to do, but they're really, really important.
Once daily dosing,
once daily
dosing, really important to facilitate
where you can.
Yep.
Yeah, and also like deep prescribing too. So that's not always an easy thing to manage, and there's some nuance there. It's a bit easier when they're later in their illness. If they're in a nursing home in the later stages, that's a lot more straightforward. But again, get help from a pharmacist. There are some online tools like MatchD that can be helpful, but you really need to think about where they are in that sort of rough 10-year estimate, and if the tablets they're on is really going to start making a big difference or not anymore. Right. So then there's the tablets that can make things worse. So, Mark, you mentioned oxybutynin. Is that on our list there? I'm trying to find it.
Yeah, 3 points. 3 points.
3 points. Yep, there it is. Yep. So tell us about anticholinergic burden. What does that mean?
So the anticholinergic burden, just try and think about it. We actually, the acetylcholinesterase inhibitors are there to actually increase the amount of choline for transmission of thought and synaptic activity. So anything that's going to wipe away choline, such as your anticholinergics, is going to make things worse. And there are lots of them because we use them a lot in treatment. So oxybutynin for bladder stabilization is obviously something that should be avoided. And often we miss them because they're a patch, so they're not in the Webster pack. And so they get lost on the skin, and we forget about them. And then we realize when we're giving somebody an acetylcholinesterase inhibitor, which has cost a lot, and they're getting oxybutynin at the same time, it's like nuts.
I think too, we often underestimate some of the side effects of these medications too. And so, especially elderly patients, they'll often have a lot of side effects from these classic things, dry skin, dry eyes, constipation, urinary retention, they're often potentially related to these medications. And what can happen is that then somebody's prescribed something else to counteract the side effects, and they end up on this sort of medication cascade, really. So, yeah, having a good look for anticholinergic burden is really important.
I'll tell you what's not on that list, which I think is really important, is digoxin. Digoxin is quite a good drug because it's got some good properties. It's a bit older style for AF, but it is thrown around a little bit, and yeah, that can really make a difference to people's cognitions. That's another one that's not on there. There's heaps of them. You need a medication review, or maybe go and have a look at an online calculator for you. So that's the things that make things worse. So I've got general principles, what makes things worse, and now we've got medications that make things better. So these are the cholinesterase inhibitors that Mark just mentioned. And the main one that you would have heard about is donepezil or Aricept, maybe rivastigmine or galantamine. Usually, personally, I'm using donepezil, but the other ones are there's like a patch version, isn't there, Mark, and versus an oral version. So you need to know a little bit about these drugs. So first of all, they do come with some really annoying PBS authority criteria, which I still need to personally lobby to get removed, because I think these were put on decades ago and have never been removed, and there's no reason why we need to have them on authority still. But if you're going to use the authority, which we teach, then it needs to be in consultation with a specialist, a geriatrician, a psychogeriatrician, a general specialist. Doesn't have to be just another GP, sadly. And that consultation could be a phone call, it could be an email, it could be a corridor chat. It doesn't have to be a consultation. So, as in, seeing Mark for an hour. Okay, so that's really useful information to know. And their mini mental state needs to be over 10. Because if it's less than 10, that may signify a much later stage in the illness, and it doesn't make much difference. It's better early in the illness. What you're looking for, and if you look at the research here, it's very vague, but it talks about modest benefit, changing cognition. They've, in the research literature, they've used sort of scales, asking patients and carers questions around, is their memory better? Is their function better? And really what you're looking for is asking the person, do you notice a difference? In my experience, it's normally the carers who tell me they notice a difference. And they might say things like, Nan's a bit sharper, a bit less forgetful. They're more interactive, they're more social in the family situation. And they're positive outcomes. And you do need to be aware of potential side effects. Gastrointestinal upset's common and should be talked about, and you should start people, if you're using donepezil, which is 10 milligrams, start them on 5 for 2 weeks, maybe 4 weeks even, before you put them up to 10, so they get used to the medication. You need to do an ECG. If they have a significant heart block, it's contraindicated. And you just need to monitor them quite closely, because falls is potentially another risk, or a deterioration if they've got uncontrolled asthma. So they do have some challenging side effects to discuss for drugs that have modest benefit, but we don't want to scare you away from them, because some people do get some really positive benefit. Some people have side effects and you stop them, but they are worth having a think about for Alzheimer's dementia. Is that a good, have I done, Mark? Would you add anything to that? That's my GP approach anyway.
No, I don't think I'd add anything to that. I think that's fair. I'm a fan of galantamine only because it has less cardiovascular side effects. That's what the data suggests. But I would still want to do an ECG before I've started people on the acetylcholinesterase inhibitors, because if they've got a heart block, it's awfully embarrassing when your cardiology friend says, I've just dropped the pacemaker in Mrs. So-and-so. And they haven't picked up that they were on an acetylcholinesterase inhibitor, but there we go. And it's happened. I'll put my hand up for that one. And lowering blood pressure. So on average, the blood pressure drops by about 6 to 8 millimeters of mercury across most of the acetylcholinesterase inhibitors. So watch the summertime initiation. Sometimes can be a bit tricky.
Is that why falls is a risk?
That is probably the most likely reason. Yeah.
Yeah. And just remind me, which is the patch one? Is it galantamine?
That's rivastigmine. Rivastigmine is the patch, and there's a relatively high incidence of skin irritation with the patch. So it's actually got some great evidence in Lewy body dementia, rivastigmine, but the rest of it is not so strong as to sway me from either using donepezil or galantamine. Having I did the original studies with the phase 3 studies in Exelon in its day, and that was with a tablet form. But the tablet form caused a lot of gastrointestinal symptoms very immediately, and so the tolerance for it is less than the others that cause their gastro problems about 2 weeks later. So I always say, don't blame your favorite pub's cooking for some diarrhea 2 weeks after starting these drugs, because that's always what happens, and they don't go back to the pub again, which is probably a good idea, but not good for the pub.
My experience is that if they're getting a lot of gastric upset, change to a patch. Is that's what I've seen up here? Is that?
I've tended to just dose reduce and give them another try.
Yeah.
And if you think about the side effects of the anticholinergics being constipation, then it makes sense that the side effects for these will be sort of diarrhea. And likewise with urinary retention, the side effect here might be urinary incontinence.
Yep.
And Pete, do you mind if I just add one thing that, there are two absolute contraindications, and they are active peptic ulcer disease and GI and ureteric obstruction. And then there's a fairly, as you've already talked about, the cardiac and the respiratory disease are also sort of significant considerations as well.
Fortunately, active peptic ulcer disease is pretty rare these days.
True.
Much of it.
If they've had peptic ulcer disease, you do have to be careful. And, certainly if it seems like it's recurring, or you're starting to have symptoms of gastritis, etc., stop it. Stop it and talk to your geriatrician. Yeah.
So, Mark, I don't see much of memantine thrown around up here. What do you use much of it, and what would be?
I do in my nursing home patients, because the data around memantine is that in fact it has its best effect in some of the sort of anxiety, the repetitive behaviours and distress the patient appears to be in, which is a cause of concern for them and for their families. I'm often adding it now to the acetylcholinesterase inhibitors rather than stopping one if they're on those. And then what I do is I suggest we give the cholinesterase inhibitors by private script and the memantine on PBS, because the memantine's a bit more expensive still on private script. So, and it really is not that expensive now. The acetylcholinesterase inhibitors, I think, are around about $45 a month or something like that. That's not. Is it that much? I can't remember now.
I think it's about $14 or $15. I think it's really quite cheap now, the cholinesterase inhibitors. I'm pretty sure. I was talking to Step about that the other day.
Oh, okay. That's a lot less than I thought. Maybe it's the memantine that's 40 then. So, yeah. So families are pretty happy. And I've actually really been surprised. I've had some very positive responses to the use of memantine in BPSD. You've got to get to the bottom of the BPSD. But if it's one of those, if it's often because there's just cognitive dissidence for the patient, they can't work out where they are, they can't be sure about anything, then sometimes adding memantine means that you reduce that cognitive dissidence for them, and they begin to settle into the environment. So they're more comfortable and they feel like they're knowing where they are better.
There you go. Do you need authority for memantine and to speak to a geriatrician?
Yeah, you do if it's the PBS, but if they've already been on galantamine, they've already got the diagnosis, so you can just swap them over. You don't need another authority.
Oh, yeah, great. Yeah, great. Okay, good. So there you go. So there's a tip for your patients, those of you looking after patients in nursing homes with some behavioural disturbance. So they're your two drugs. We're not doing the monoclonal antibodies because they're not yet available in Australia. That's for an up-and-coming webinar if that happens. So the next thing is driving. I'm just showing a bit of time. So the next webinar 3, goes through in much more detail 2 cases, one driving and one legal. So you're going to get much more stuff on this. So we're just going to do basic principles, but you just need to know what to do at the beginning of a diagnosis of dementia, and they say, can I keep driving? So the basic principles are to have the conversation early. If the patient's showing you good insight into their understanding that eventually they're going to have to stop driving, then that's a good sign. If they show absolutely no insight at all, then that's a red flag. Mark's favourite line that I now use all the time is that driving is a privilege, not a right. A bit like being a doctor, which I was talking to one of my colleagues when this whole stuff around testing capacity as you get older. I probably should bring that up tonight, but again, driving is a privilege, not a right. And so part of our job, I say to patients, with any illness, is that we keep assessing driving, And just because you have a diagnosis of dementia doesn't mean you lose your license straight away. You still have to take every case on itself, and you need to make an independent assessment at that moment in time. Um, and often my patients who have a very early dementia are still able to drive. But when you talk about it in more detail, and you start talking about it, and the care is in the room, and there's more understanding of the illness, and I'm saying things like, it will come to a stage where you have to stop driving. It's not today, it may not be in 6 months, but it might be in a year or in 2 years' time. Then I'm surprised and pleasantly surprised by the number of people who actually say, you know what, I don't want to do it anymore. I'm too anxious about it. I'll just let my carer drive, my partner do the driving. So it's a good get out of jail card free card for yourself in that conversation. So that's the sort of conversation. They're sort of my tips. We'll go. You get more detail about that in the next webinar. But just moving on now to the conditions. So you do need to know that there are some things that you need to be able to drive with cognitive impairment, and you should make yourself familiar with the fitness to drive licensing guide from Ausroads, which is excellent, isn't it, Beck? It's got a really good section on cognitive impairment.
Yeah.
Definitely. If you read it after this, you'd just be like, yep, everything Beck and Mark and Pete just told me, tick, 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 and it will all make sense. And it's good to sort of go through those things with someone, Can you really think about visual spatial here? So the clock face test, left from right, changing lanes, approaching a roundabout, getting lost, finding your car, these kind of things. And the other tip I would give you would be much more confident in someone who drives short distances every day for the last 10 years, who wants to keep doing the same thing, because that does involve a lot of long-term memory. If they then say, oh, no, I still want to be able to drive, what happens if I want to go on holiday and drive up to Queensland 3 hours away? I'm like, no, sorry, can't do that. Because think about what happens then. They're in an entirely new situation they're not used to. There's much more cars on the road because they're in the big city. There's traffic lights. There's a whole lot of range of new stimuli that are coming at them really fast, which is not good for someone who has cognitive impairment. Is that fair, Mark? That's what I say.
Look, I think it's a clear indication.
It depends on their level of dementia.
It's insight. It's insight.
Yeah.
And someone who turns around and says, oh, yeah, look, I don't drive much, but I always want to have the car so I can drive to see my daughter's place up in Queensland. I'm thinking, no, this is someone who's not actually thinking it through properly. Whereas you get the other person says, look, all I want to do is get to the supermarket. And I say, when do you choose to go? Look, I don't want to drive at dusk. I don't want to drive at dawn. And I never drive when the kids are coming out of school or going to school. You think, rightio, that's pretty good. And this person will choose to stop at the right time.
Yeah.
You can also put restrictions on too, can't you, Pete? Like, there's lots of restrictions that we're able to put on. So I don't know if you're going to talk about that in the tick. But
oh no, I mean yes, worth talking about.
That's worth being aware of.
Sorry, Beck, your internet's just cutting out then. But yeah, Beck's basically saying being aware you can put restrictions on how far you're allowed to drive, daylight, nighttime driving. Asking a bit of a history. Have there been any crashes in the last 12 months? That's a bit of a red flag if there have been. And the one I love is getting the family or care partner in the room. So, have you been in the car with the person? Oh, yes. And who was driving? I was driving. What about when they were driving? Oh, no, I'd never let them drive me anywhere. But then the person goes, but I can drive by myself. That's obviously red flag. And if you're all unsure, there's uncertainty and they're very insistent and you're not sure yourself, you can, although it's expensive and sometimes hard to access in the regions, an occupational therapy driving assessment, which is about 4 or 5 hours long, is the gold standard. The mini mental state examination is not a good predictor. And why is that, Mark?
It just doesn't pick up. It is good, okay for visuospatial, and that's the intersecting pentagons, but it's not a very, very simple test. But without the clock drawing test, it's not a good predictor at all because of the fact that it's really driving is executive function and visuospatial function. You don't need a lot of memory because you've got working memory going all the time because it's an active task, except you do have to think about your rear vision mirror and side vision mirrors occasionally. So, but often that's just working memory. So it's visuospatial function and executive function, planning and awareness.
And we'll talk about these in the next webinar, but if you haven't seen them before, there are these extra visual spatial executive functioning tests you can, or assessments you can do, sorry. There's the trials A and B. There's the Snellgrove maze. You time them and count errors, and then you can get a score, and that can give you an indication of how well they're going. So we'll go over that in more detail in the next webinar. And that's driving. Any questions in the question box? It's always a good,
Not yet.
Good topic. Not yet. Good. Excellent. Doing a good job. So legal. So there's different legal documents. So again, we go over this, and I'm used to doing this with Mark, so I'll just ask him quickly because I love his answers. So Mark, do you ever give anyone, if someone says, oh, the lawyer came to see me and said, you need to give me capacity to be able to give all the house to my third daughter once removed cousin, what do you say?
I say that's a legal question, and I will make sure that you're as well as I can possibly make you, so you can go and see your lawyer and demonstrate that you to his satisfaction or her satisfaction, that you can make that decision. Our job is to get our patients well. Our job is not to make a legal decision.
And if they say, oh, my lawyer's told me to come and see you and fill out this thing called an advanced health directive, what would you say then?
Well, if it's an advanced health directive, then the lawyer, that could be signed by anyone. If you look at certainly in Victoria, it doesn't have to be signed by, it can be anybody, a justice of the peace or anything. So there's no medical requirement that a doctor be actually the witness for that. And you can have family or friends who are not immediately related to sign off on an advanced care plan. And it's a pretty basic decision for most people, unless they're very, very severely impaired, which they shouldn't be. They're probably the horse is bolted for that one.
Yeah. So great advice there from Mark is that don't be a lawyer. If someone wants to get capacity assessed on a legal decision, who gets my money, who's in charge of my bank accounts, how do I sell the house, all those things, that's the lawyer's job, because they're assessing legal capacity, not health capacity. You know, if you want to do an advanced health directive and say, do you understand what it means that someone won't do CPR if blah, 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 that's completely fine. And the other one about legal is to get someone to point a substitute decision maker. So they're called guardians where you and I live in New South Wales, but in Victoria they're called something different, aren't they?
They're called the enduring power of attorney.
Yeah.
So there's medical treatment decision maker in Victoria who provides medical decisions, and then there's an enduring power of attorney for legal and lifestyle purposes. And we get a bit involved, Peter, in enduring powers of attorney. But just as an example, this week I was speaking to a GP colleague of mine as a lady with an MMSE score of 18, who's I said has got vascular dementia. And she needs an enduring power of attorney to go to residential care because they won't take her otherwise. And then it's a whole VCAT or administration tribunal. And I've said, yep, she's got capacity. And he said, but the MMSE score's 18. I said, but she's the only person in the world that knows anything about her apart from Winsome, her 86-year-old friend, and there are no other family. It is not a hard decision for her to give an enduring power of attorney to Winsome. Okay, because it's not. It's like saying, would you like sugar or milk in your coffee? You can say that too with an MMSE score of 18.
Yeah. So, Bex, do you have anything else to add there? I think that's the basic points about legal stuff. Getting
Yeah,
early.
I get in early. Ideally, we've done this even before people have a diagnosis of dementia. And also, I think having the advanced care directive handy is quite useful too. I always suggest they have it near the front door, because if they do ever have to take an ambulance somewhere, then it's very easy for them to be able to take it with them. Because the last thing you want is to have done all of this and then they get to hospital and there's no record of it and they're sort of overtreated essentially. So yeah, have it close.
And it's worth making sure that it's up to date too. So I just had to, one patient of mine's wife is now in not that well in an aged care facility. Another one, their wife passed away, and so if they're still the enduring guardian or the responsible person in the advanced care directive, that all needs to be changed. So just remember to have a look at it every few years and make sure that it's up to date.
Generational shift down is really, really helpful, because so you want often you might have the partner, but as a second, you have a daughter or someone else the next generation down.
Yeah. Yeah.
We've got a question on the line, Peter.
Yeah.
It's an interesting one. A doctor's legally obliged to comply with an advanced care health directive. It depends whether it's a values in Victoria. It depends whether it's a values directive or a treatment directive. The Jehovah's, they've muddled up in Victoria the need for Jehovah's Witnesses say I don't want blood, and they can produce, they can write up an advanced care directive which says I do not want blood, which is a legal directive. But I never recommend any of my patients to have a directive advanced care plan. I say it should be a values advanced care plan, which says I really want to be able to have an interaction with my family. I want to be able to feed myself. I want to be able to mobilize in a wheelchair, because they're values directives, and then we have to make that decision. So yes, doctors are legally obliged to follow an advanced care directive if it's a treatment directive. So I never say, I always recommend patients to say, don't say, never want to have an ECG or never want to have a DC reversion, because it just doesn't make any sense.
So we're nearly there. Last one is the GP management plan. So Beck, you talked about this earlier. I think most GPs know how to do this, but they may forget things, particularly around dental and nutrition with dementia.
Yeah, I do think, really important things that will often get missed are things like dental health. And again, addressing that early is really important. It's quite tricky getting dentists to come out to nursing homes, and it's difficult to have teeth managed as a dementia progresses. So dental is important. Bone health is really important and something we should consider early, and addressing falls risk. And then looking, as you've said, at hearing and at vision, because any sensory impairment is going to make it more difficult for the person living with dementia. And we tend to keep an eye particularly on weight, because that's a very good way of helping assess both nutrition and how well, if somebody's living at home, how well potentially they're managing their nourishment. But I think the whole concept of the GP review is really good if you use that checklist and just keep reviewing it, because at each stage our goals of care are different, and so you just have to make sure that you review it on the 3 to 6 monthly basis, as we should be doing anyway.
Yeah, and it's a good way to get remunerated too.
And the practice nurses can do this really, really well.
Yeah, absolutely. And then this is just a shout out to our allied health professionals. Beck talked about OTs being underutilized. I agree with that. Exercise physiologists to maintain activity and muscle strength in the legs so they can get in out of the chair, especially if you think about like a big sort of 110 kilo, 120 kilo person, and then the partner's smaller and not as strong. Like if they can't get out of a chair, well, that's, aged care facility. So that sort of thing is really important. Psychology can also be really important for someone with some mental health symptoms.
And I think it's true for the carers as well, Pete.
Yes, that's right, which is our last dot point. Family care partners. So don't forget the carer in the room. This dementia has a massive burden on carers. We talked about that in the first webinar, and recognise the impact on the family. I often say, have you got your own GP? If they're my patient, come back and see me separately. Carer burnout is real. It happens and needs to be supported. And particularly, it might not just be burnout from caring, but there might be changing behaviours that are really stressful for the family and the carer too. So Dementia Support Australia is a dedicated resource we talked about earlier, 24-hour service to help both you and also the carers for people with behavioural changes in dementia. There's a nurse on the end of the phone, so that's a really useful resource. And yeah, you just really need to think about the whole team, which includes the carers.
There is also a bundle of Commonwealth Health service providers that are available through community rehab services and also in the community, which we use a lot now for our mild cognitive impairment group, where we want a combination of exercise physiology, dietitian, and social for cognitive activity. And they can be, so long as they're not on an aged care, a home care package, they can get access to all of those things. And often if you get to one of them, like the exercise physiology, they'll often cross-refer into the other parts of the system. So patients get complete post-diagnostic care in both the MCI and the early dementia stage.
There's the resource for Dementia Support Australia with the phone number down there. You can Google that pretty easily too if you need to. And there we are. Oh, what was that? Sorry?
I didn't want to steal your thunder. There's a GP helpline, the Dementia Support Australia. So certainly the carers are able to contact that, but also GPs can contact that. They sort of send off an email. It's not an immediate response, but if you're having a patient who is showing significant change behaviours, you can send off an email to Dementia Support Australia, and they often will sort of come and make a fairly thorough assessment, which can be helpful too.
So we're at the end. Because the Lancet article came out, I haven't updated my last slide. That's 45% of dementia is attributable to modifiable risk factors, up from 40. Hopefully you feel much more confident now being able to do this kind of work. My advice is do it with your colleagues. These patients often very rewarding. I really enjoy this kind of work. Talking to your colleagues about it, I think, is a really good idea to get help or debrief or just out of interest, or your practice nurses. Get stuck into it. And just, I know there's no cure for dementia, but always remain hopeful. There's lots you can do, which we've talked about tonight, that can slow the progress and really give people meaning in their last stage of their life. So make sure you scan this QR code and evaluate. Face dementia is part of a research study, isn't it, Mark? And they really want to get your feedback.
Yes, please.
So I'll bring that one back in a second. There's the resource QR code again. And DTA has some really cool resources too. Probably the one that would shout out the most is the one on the right there, the podcast, which has got some great stuff on it. But I'll just put back that one.